Good afternoon. My name is Prabhakaran. I'm a cardiologist and an epidemiologist, and I'm currently Vice President Research and Policy at the Public Health Foundation of India. Welcome to this TV show. We have a very distinguished guest here, Dr. Regina Benjamin, who was the Surgeon General during the period of President Obama, and she has several other awards, qualifications, and I can go on and on, but I want to read out a few. She's an American physician, formerly Vice Admiral in the U.S. Public Health Services. She served as the 18th Surgeon General of the United States. In 1998, she was awarded the Nelson Mandela Award for Health and Human Rights. She has the badge of Office of the Secretary of Health and Human Services. She was American Medical Association Foundation Leadership Award, and she was recognized by the Time magazine in 1999 as the nation's 50 leaders under 40.
Right.
And she also received one of the most inspiring awards called the National Caring Award, which was inspired by Mother Teresa.
Yes.
And there are many, many more such awards. I don't want to get into all the awards because we will finish off this whole half an hour with that. With this background, I read through your CV. Your early life was very, very inspiring. Please tell us briefly about that.
My early life?
Yeah.
I grew up in a small town in Alabama, and basically had a normal life. We weren't very wealthy. We were poor, but I didn't know we were poor. So because we had enough to eat, we had land and that sort of thing. But my mother and my grandmother always taught us that we should do for others. And so I grew up with a sense of service, and I learned that from them. And servant leadership is so important.
Right. Can you talk briefly about the rural clinic that you established and how it opened up your horizon in terms of the health systems in the United States?
So when I was, as you mentioned, I was active in the American Medical Association, and I attended their meeting, and one of the intense issues that was being debated was that sexually transmitted diseases needed to be taught in medical school. So I stood up in a room with maybe 15 people, and I told them I'd never seen certain diseases except in a textbook, and I thought there was a need. They passed that resolution and they forwarded it to the American Medical Association. And once they forwarded it, they sent me to speak to it. And the resolution passed. And within 6 months, every medical school in the United States was encouraged to include sexually transmitted diseases as part of their core curriculum of all medical schools. So I learned that one person can make a difference, whether it's in medical policy or in medical practice. So I learned I can make a difference when I went to my little small town of 2,500 people and started practicing medicine there.
So from the proverbial young boy who was trying to save one fish at a time on the long beach to a good shepherd, how did the transformation happen?
Well, that starfish thing, it does make a difference what you do one person at a time, and I still believe in that. I believe that once every person we interact with matters, and that if we can just make a difference for one person, you'll eventually make a difference for everyone. When I left to go to the national and international stage of medicine and prevention's my whole thing, I just went from being a doctor, the only doctor in town, to be having 300 million Americans as my patients. And so I just looked at it the same way. The same thing with policies. We make sure that the policies that we put in place can affect people in a positive way. We first do no harm. I want to make sure that we can get people access to care and those sorts of things.
So in your acceptance speech as Surgeon General when President Obama invited you, you expressed your dissatisfaction with the health system. How did you go about changing it?
Well, I wasn't dissatisfied with it. I just felt like we needed to cover more people who didn't have access to care, and people who didn't have a way to get to the doctor. They didn't have insurance, in our case, to pay for it. We needed to make it available, and we also needed to give people an opportunity to be healthier. And as I always say, we needed to make the healthy choices the easy choices. And it's hard to be healthy if you don't know where your next meal is coming from. It's very hard to be healthy if you don't have sidewalks to walk on, if you don't have the infrastructure in place. And I think that's one of the roles of government, is to help that. So we needed to put together some sort of plan to make sure people can be healthy and encourage them to be so.
So in India, we are at the threshold of making history in terms of healthcare, modification of the health systems, and so on. Before I come to that, I just wanted you to share your experience on the Affordable Healthcare Act and the so-called Obamacare, and how it transformed the United States. What are the challenges that you face? What are the things that you changed? It will be very useful for us in terms of lessons learned from there.
So with the Affordable Care Act, or the Obamacare, we went through the political process of debating back and forth, but at the end of the day, it was the right thing to do. We tried to put things in place that would protect people, protect the fact that they needed access to care. So one of the parts that I was responsible for once it was passed and was the part about prevention. The Affordable Care Act had in it the National Prevention Council, 17 cabinet level members who reported directly to President Obama, the Secretary of Health, the Secretary of Labor, the Secretary of Transportation, the Judicial, which is the Attorney General, all sitting around the table for the first time to talk about prevention. And I had the honor of chairing that council called the National Prevention Council. And so we developed what's called a National Prevention Strategy, and that strategy is a roadmap to being healthy. The U.S. uses it, many cities use it, a few countries are using it as a roadmap to try to figure out how to make a healthier community, a healthier population. And so prevention is the start. And one of the things in the U.S. and other countries is we're very good at tertiary care. We're good at treating things after they get bad. We need to go upstream and try to prevent people from getting sick in the first place. And so that's the whole idea, is let's try to do what we can to either prevent them from getting sick or preventing it from progressing.
So I think it has a lot of lessons for our healthcare too. And if I were to briefly tell you about the Prime Minister's plan, which is called the Ayushman Bharat, I think it's a very revolutionary idea. In fact, when we talk about affordable health care, we probably spoke about 10, 20 million people, I'm not sure how much. But in terms of Ayushman Bharat, I think we're talking in terms of impacting 500 million people. And there are two revolutionary ideas in that. One is redesigning primary care, where we're going to have 150,000 health and wellness centers, which will focus on primordial prevention, health promotion, and lots of other things that you spoke about. And in terms of secondary and tertiary care, it speaks of financial protection for individuals. As you know, catastrophic illnesses can push people into poverty. I think a quarter of urban people and rural people are pushed into poverty because of catastrophic illnesses. And in that sense, it's going to protect millions of people. So, from your lessons in the Obamacare, what is your advice as to where should we see what the problems are? What do you think, some nuggets that you can give us?
Well, my idea is all about prevention. So I want prevention is to be a key and a basic part of any plan. And I think that would be a good platform to be on, particularly at the primary care stage and in the early stages, and giving people an entry into the health system itself. You should be able to enter it before you get to a catastrophic time. You got to start somewhere. It's a big problem. It was a huge problem for us. It still is a big problem, but our numbers are much less than the numbers you're talking about. But those are the people that can be helped. And so you have more of an opportunity to help people. It's nothing like having a mother who has a sick child and don't know what to do and don't have anything to do. It's so heartfelt to see a mom who wants to do something and can't, and we should be able to help them get access to that care. The other thing is that a parent who's a full breadwinner should be able to have a healthy life so that they can provide for their families, and health is part of that. It's just as much a part as a good job, as having food on the table. Having your health really matters. I would say that people will block change. And so we saw a lot of people who were afraid of change, and change is frightening. But once they saw that this change was for the good, for example, one of the things the Affordable Care Act was, it told insurance companies they couldn't discriminate based on pre-existing illnesses. At first that was not a big deal, but now people have experienced it. They don't want to lose that. They understand that I shouldn't be prevented from having care because I actually had a broken arm one time, and so that shouldn't stop me from getting coverage. So stick to it and just do the right things for the right reasons. Yeah.
I thought I should highlight some of the differences between the Affordable Health Care Act and our Ayushman Bharat, or the Modicare as we call it. I think one of the fundamental differences is that yours was insurance based and it was compulsory. I mean, the whole population needed to have.
Yeah.
But here we are talking about close to 40% of the population. Do you think we need to extend it to our whole population? If so, what do you envisage that we should do?
Well, we talk about health equity, and so we started with, and I think you are too, starting with those below the poverty line, because those below the poverty level really are in urgent need of taking care. And you could have another phase, but at some point it's going to need to be extended because those folks in the middle portion will need some services as well. And if they're, it's their government too. So they should have some sort of access. But if you can't take care of the most vulnerable and the poorest, you got to start there.
The success or failure of every great idea is dependent on the nuts and bolts, the infrastructure. So what's your advice? What are the, let's say, 2 or 3 essential things, essential ingredients that are required moving forward?
Like I said, the prevention part, the access to care. People also need, this is new, so they're going to need some education. The patients are going to need education, the providers are going to need education, the clinicians, the government, and no one can do it alone. So in our national prevention strategy, we talk about how we need to join forces, and everybody has a role to play. Everyone in education, everyone in law enforcement, the taxi drivers, everybody has a role to play. So the more we can do things together, it'll spread out that burden. It's going to benefit everyone, and as it benefits everyone, you have a healthier workforce, you have a healthier society. So that's major. I also would say figuring out how to pay for it is going to be the most difficult. And you may get things right first, and you may have to change it and tweak it, and you may get things wrong. That's going to be difficult, but that's to be expected. But you got to start, and you got to get it started.
So to summarize what you're saying is, I think you're saying from the patients or the community perspective, we need to create awareness, we need to empower them, so that there's a demand generation from their end. In terms of the providers, I think they need to radically shift and think that they are partners in the healthcare rather than the providers, actual providers, that they're partners and influence the care. So I think there are lots of things.
So we're partners. I mean, we need to be partners, but we are providers. But we also, patients tend to believe. They trust us, and so we have a real strong leadership role because our patients do trust us. And if we say something to them, they'll trust us before they would trust someone else. So in that respect, it's much more a responsibility for providers. One of the things I've noticed here at this conference is a lot of technology, and I gave a talk on mHealth. I think technology can help bring down some of those costs by getting things out to people where they are. And so if you can get technology out there, for example, with an EKG machine, you could save people the time from coming in, but you also can catch things early. And if you saw an abnormal EKG, they could go to their local hospital, get it taken care of quickly before something really bad happened.
Right. I just, because you brought up technology, there's one more aspect which I didn't mention, because I just wanted to know your experience in the United States of task shifting, particularly nurse practitioners, physician assistants, and their role, particularly in the management of cardiovascular diseases, especially if they're empowered with simple technology. So what's your experience?
So my experience is that I was very involved in licensure and medical education, and so what we call the scope of practice, and that's what you're describing, that scope of practice extending from not just the doctor, but the other clinicians, the nurse practitioners. We have physician assistants, and we're even going now into the patient navigators. And so those other clinicians and have a real role to play because they can spend time educating, they can get to spend more time with the patients, and then when we as physicians see them, we can concentrate on where the issues are. The thing with the patient navigators and community health workers, they can go into the homes and find out, why that diabetic blood sugar keeps going up on Tuesdays or not, and that could change how we treat them. And we couldn't do that. You can't take a doctor's time to go out and find that out, but that is a major role to play. What you don't want is to have that that competition and saying, oh, you're getting on my turf, but use it as a team. And we see that the team approach is much better than individual.
So the US spends close to 17% of its GDP on healthcare. In India, I think it is mentioned anywhere between 4 to 5%, but the public sector spending is extremely low. It's around 1 to 1.5%. Now, as we are embarking on this journey, we need to definitely increase our spending on healthcare. So, what are the lessons? Because this has been talked about. Despite spending 17%, the health inequities are huge between states.
My thing is prevention. So I think if you're going to spend your budget on anything, prevention really will pay off in the long term. Clean air, clean water, those things will decrease your cost and the amount of morbidity and mortality in the long run. Tobacco, the smoking, and and as Surgeon General, that's my area. The one thing you can do to help decrease cardiac disease is just have a smoke-free society. So putting a portion and dedicating an active portion of that budget into preventive services, into public health infrastructure, just making sure we have basic clean water, basic clean air, basic vaccinations, those things will pay off in the long run.
So what I understand from what you're saying is, apart from investment in healthcare itself, what we need to do is to look at upstream determinants, the social determinants.
The social determinants, yes.
And larger policy, non-personal policy measures, if you have to...
And that's where it takes the team. It takes the politicians, the government sector, the philanthropists, it takes business people, it takes education, the colleges and universities, the law schools, all of them to start attacking it as the problem as a social determinants of health. And that's why health doesn't just occur in the doctor's office. It is all of what we're doing. In order for us to truly be healthy, we need to be healthy everywhere we are, at the work site place, when we're driving our car, every place.
The last question I wanted to ask you is, as a Surgeon General, you had a mandate with regard to the health. But as we know, health is beyond the domain of health providers or health policy makers. It's a multi-sectoral concept. How did you manage that multi-sectoral dialogue, and what lessons can we learn from that?
So it was pretty easy once we put in the National Prevention Strategy, because we've got a lot of input from various organizations, various groups. We got the business group on health with the Fortune 100 companies. We had different people that started to understand that they had a role to play. And as I went around the country and actually the world to talk about how we all can make a healthier society, people started taking responsibility, because the companies, it was taking a big part of their budget, especially the NCDs. The country's GDPs are starting to be affected. So everyone knew that we have to attack it as a group. And as I think as physicians, we can be leaders in that. And we have to play a major role, but we need to engage other people to help us do that.
So, Dr. Benjamin, on behalf of CSI TV, thank you very much. It was wonderful talking to you, and I think we have lots to learn from you, and we also have some lessons that you have learned, which...
We've learned a lot. I've learned a lot, and I think the U.S. can learn a lot, particularly around tobacco. I'm very pleased with your leadership the country has taken in banning e-cigarettes, having the 85% package cover, so those things we can learn from you. And so there's mutual relationship.
Yeah, bi-directional, yes, we call it. So thank you very much.
Thank you.